When we were little, we would have tummy aches that mom could fix. But if it's abdominal pain that just doesn't go away, it's time to get some help. The many causes of abdominal pain, tonight on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. There is something special about abdominal pain. The abdomen is our center, our core. If there is a problem there, it affects our whole health and how we act all day and when we try to sleep. First, let's take a look at this week's Prairie Doc quiz question. The most useful tool in the diagnostic abdominal pain category, the most important tool is A, ultrasound, B, X-ray, or C, a patient's history. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, you only have 10 minutes to get your answers in. We answer your questions, though, throughout the night about abdominal issues as they're called in or sent to us via Facebook or email. Call in your questions to 1-888-376-6225 or send us an email to the address on the screen. And I must say, I really am asking you for questions because this is such a fabulous topic and it's so broad, it carries so many possible options of discussion that we'd really like you guys to lead the discussion. So please, please give us a call and ask your question. Joining us tonight is Dr. R. Towner Lapp. I love that name, Towner.
Oh, thank
Everybody
you.
loves that
Family name.
Towner Lapp with Avera Medical Group Gastroenterology. And Dr. Jeff Johnson, that's kind of a common name. Everybody has that name. I mean, you know.
There's actually 4,700 of us in the U.S. A friend of mine sent me a message about that the other day.
Kind of a boring name. Not really. Jeff Johnson with Avera Medical Group Specialty Care Brookings, a surgeon. So we have a surgeon and we have an internist who is a specialist in gastroenterology. And then we have this old codger who's kind of a psychiatrist, somebody said. Actually, more of a general internist. But we are going to enter into this discussion about abdominal pain. And part of the reason why we picked this topic, and I particularly have an interest in this, is because 2 years ago I came down with an abdominal pain. A smooth muscle tube was obstructed. I couldn't find a comfortable spot. I'm roaming all over the room. I'm trying to find a comfortable position, and it was pancreatic cancer, blocking a smooth muscle tube. And Towner was a person who helped with me, and Jeff was a person who helped me as well in this voyage of trying to find the solution and coming to the solution and the treatment, and I thank you both for your help on that. But so I'm going to just ask a little bit about your history first. Towner, you're from where, and where did you train, and what's your story?
I grew up in Sioux Falls, went to Augustana, USD Med School, and then I did my medicine at University of Wisconsin, my gastroenterology at University of Nebraska, and I did a subspecialty within GI called advanced endoscopy at the University of Michigan. When I was finishing that up, knew I wanted to come back home, so moved back to South Dakota and now work for Avera McKinnon.
You're a South Dakota boy.
Yep, through and through.
Through and through. Now, Jeff, you're not a South Dakota boy. You're from. What's your story?
It's a little more eclectic. I grew up in Denver, Colorado, and actually came up to the Dakotas to pursue a career in aviation. And I went to the University of North Dakota for a little while, met my wife there. Then changed my mind and decided I wanted to do something a little different. I wanted to go into medicine, so I went back and finished up some undergraduate work in Colorado, and then went to a small medical school in the Caribbean. Spent 2 years down there. Did most of the books, lectures, tests, didactic portion of medical school there, and then came back to Kansas City, where I did most of the clinical work of medical school. And then stayed in Kansas City for my general surgery training at the University of Missouri, Kansas City. And I practiced for a little while in the western side of Colorado, but my wife's family relocated to Sioux Falls. And when I found out that there was a job in Brookings available, I had been through Brookings many times on my way from Denver to Grand Forks, and I saw it was a great, vibrant little community just from the interstate. And as soon I saw the job opening and applied, and I've been here for 5 years now almost.
We are really pleased to have you here.
Yeah.
But abdominal pain is our topic, and so we have really great experts. But let's talk about it. It's such a broad topic. Towner, if you're going to make a brush and explain abdominal pain, how much of it is really dangerous, how much of it is a kind of a chronic pain that you never discover? I mean, how much of it is give me your broad brush.
You know, we see, I would say at least a third of my clinic patients have abdominal pain of some sort, whether that's more on the acute side or chronic, but the majority of what I see is chronic, as opposed to the acute severe pain, I need help now.
Appendicitis kind of pain.
They're typically going to the ER to get immediate help.
Yes.
We would need multiple shows to go over all of abdominal pain. It is broad and complex and can do just about anything or be caused from just about anything. But some of the common things that we see in GI clinic, you know, we can treat, we can evaluate, but it can be anything from a gallbladder that we need Jeff to help us out with. It can be from an obstruction in the pancreas tube caused pancreatitis, a bowel obstruction, or it could be they are normal, quote unquote, and they still have abdominal pain. We got to treat them.
They have pain, don't know the cause, workup done, don't know the answer. And there's a lot of people with that.
And it gets frustrating for the patients, and it's a long-term strategy that we need to have to kind of manage and try to help them through their pain.
And so I'm going to ask you the same question. Your perspective is different as a surgeon. How would you look at it?
Well, when people ask me why I went into surgery, I have many different answers. One of the answers is that I like, most surgeons like targets. So we have a specific target that we know we're going to go in and take care of. So with regard to abdominal pain, somebody has pain on the right side of their abdomen, maybe they're a young, healthy male. I mean, the diagnosis there is almost certain with just an exam and a history and an exam. Perhaps it's a woman in her 40s that has had a couple of children, and the pain is more in the upper part of her abdomen. I mean, that again, the target is perhaps most likely her gallbladder, and we know that just from the history and the physical exam. Towner mentioned bowel obstructions. You know, you've got this 30-foot long tube that kind of snakes its way through this bucket that is the abdomen, and it's like a river. It should be running all the time. And if you get a block or a kink in that tube somewhere, that river has to go somewhere. So usually people will start to develop this cramping, bloating sensation, and they'll start throwing up. And really the most common reason for that is guys like me have been in that abdomen before and done something which creates scar tissue, which is almost like cobwebs sort of forming in between the intestines. And as the intestines are slipping around and sliding, they kind of get kinked. And
in the cobwebs.
In the cobwebs.
Adhesions, as they say.
Yes.
We have a lot of a problem with adhesions, and then when you go in there to fix the adhesions, you make more adhesions.
Correct. Correct. That's why oftentimes somebody comes in with a bowel obstruction, we will attempt to treat them non-operatively. They get we torture them with a tube into their nose, down into their stomach to decompress what can't keep moving through. It's usually very difficult for the patient to have that tube put in, but they almost always feel better afterwards. They're less bloated, less obstructed. And oftentimes the kink will relax and they will not need surgery. Because if they do need surgery, what are you going to do? You're going to go in there, you're going to cut the cobwebs, free up the obstruction, and all those adhesions are going to stick back together.
I think one of the benefits in our clinic, maybe compared to yours, is the majority of patients have already had a workup. They've had their labs. They've had someone lay their hands on their abdomen. They've had a CAT scan 90% of the time. So that rules out a vast amount of things, acute things, when they come to our clinic. So it helps us out tremendously when evaluating a patient in our clinic. We have that benefit of hindsight almost with all that information already available.
I will say though that all those tests are many times wrong.
And on that note, you also get a lot of the easy stuff has sort of been weeded out. So
yeah,
you get the hard stuff.
There you go.
You get the challenges.
Yes.
So that is really true. I know there's a lot of mysterious things that can happen. A lot of people who will have the lining of the uterus that escapes outside of the uterus and it goes out into the abdominal cavity. Explain me.
Endometriosis.
So what is that?
That is lining, like you said, of the uterine cavity somewhere else. We maybe get the consult for, well, I have abdominal pain around the time of my cycles, and I may have a change in bowel habits. Is it endometriosis in my colon? And so we can do colonoscopies for it. The yield is low. Ideally, they're done during the time when they're having pain. Even then, we may do it, and it may be there. We just can't see it, or it may be on the outside of the bowel. It's a tough diagnosis. The majority of the time in those patients, the OBGYN who may have referred them to us is seeing the patient again to kind of do their part of the workup.
And so they've got within the abdomen, outside of the uterus, little implants of lining of the uterus that bleeds every month, and then it hurts every month.
Right.
A chronic, recurring abdominal pain, but there's nothing to do for it most of the time. Maybe surgical.
It is possible to go in with the gynecologist will put a long scope with a camera on the end. That's called laparoscopy, and they can cauterize or ablate those small deposits of the uterine lining. And some patients will get relief from that. But there's some patients that the disruption of that area, the peritoneum, the lining of the inside, is just, it's been disrupted, and they continue to struggle with pain.
Eating regularly is important for our general health. When there is a change in our eating habits, it may be an indication of an even more severe problem.
It was maybe 2 years ago, this past summer, and I don't know, just something didn't sit right. I didn't really have an appetite, and I love food. Yeah, and just nothing really sat well. I could eat small bits and pieces, but you know, big, large meals like before I couldn't really handle. I just didn't really have an appetite. So kind of just put off symptoms, kind of hoped it would go away. My sister, who's a nurse, suggested, you know, maybe you go check it out, go to our primary care physician and see what he has to say about it. And he looked at me, kind of did an examination. Everything was normal from the outside, because, you know, I think I was 19 at the time, and 19-year-old kid in fairly decent shape, and couldn't really tell anything was wrong from the outside. So I kind of just waited it out a little bit. I went to a different primary care physician, and they referred me to a gastroenterologist who ended up doing kind of a scope of my esophagus and where my esophagus and stomach meet up. And he did notice that there was some kind of scarring or a little bit of redness, an abnormality, I guess, of the tissue down there. And so they put a capsule kind of at the base of my throat and gave me a little sensor to monitor acid levels. And I would press a button whenever I kind of felt pain or felt my symptoms coming back. And when I was eating and drinking and stuff like that, I would just kind of monitor the situation. The process that I was told was they take the top of the stomach and kind of wrap it around the esophagus. And then for me, because I had one side of the muscle that was a little bit thinner, they moved my esophagus up to kind of recreate the curve that's supposed to be in your stomach to kind of reduce acid levels going in and going up into your throat. Afterwards, it's pretty difficult to readjust your diet. Even simple foods, water was tough to swallow. I was put on a diet for about 6 to 8 weeks of, you know, strictly soft foods at the beginning, strictly like chicken broth, beef broth, cottage cheese, what have you. And because I was so young, the doctor kind of progressed me a little bit further along a little bit quicker. So instead of 6 to 8 weeks, I was done with the diet in about 4 to 5 weeks. But as of then, I kind of slowly progressed off the pills that I was taking beforehand. And since early August, I hadn't had an episode or really hardly anything to complain about.
That guest was a special friend of ours of our program. He is our special assistant and has been involved with the production, and we thank Tyler for his willingness to be on the show. Thank you, Tyler. Well, he's got a Nissen plication. He's got an esophageal reflux issue. It's an abdominal pain, but it sometimes could sound like heart pain. And so he is probably taking a proton pump inhibitor, one of these Prilosec, omeprazoles, Nexium kind of pills. There's a bunch of different kinds. What is your take on that kind of medicine?
To empirically be on a PPI, so to speak, we see, I would say the majority of patients who come to our clinic for whatever their complaint is are on a PPI. We have people who are on it for acute issues. If they have an ulcer in their stomach, that'll help heal that ulcer. Some people require long-term acid reflux medications that have an indication for it, such as Barrett's esophagus or eosinophilic esophagitis or esophagitis in the past. There are side effects of these medications, and that's one of the newer, in the last few years, people are getting very, very concerned about these side effects. And so I think it's having a conversation with the patient. Do you actually have acid reflux? I think is the key question. And do you actually need your medication? Can we get you off this medication? Or do we need to be on it long term? And can we find the lowest dose after we've talked about the side effects and everyone's agreeable with that?
I know that the side effects are, I think, have been a little bit overblown.
100%.
And I would also say this, that if you stop your PPI abruptly, you're going to have rebound reflux.
Yes.
And it's going to be, oh my God, I need that medicine. And the answer is you have to taper it slowly, like 3 months of a taper or something like that is what I've read. Any comments, Jeff?
Sure, yeah. I see, as a general surgeon in a town without a gastroenterologist, I do get quite a bit of referrals and discuss gastroesophageal reflux with patients. And yes, most of them are on long-term proton pump inhibitor, PPI therapy. And I've really, I think the indication initially of the PPI medication was brilliant. I mean, it will cure esophagitis.
We used to do surgery for GI bleeding all the time.
Yeah.
Well, it will cure esophagitis, and it will cure a ulcer as a rifle shot. It goes right to the cell that's making the acid. The stomach is still allowed to produce fluid as it's supposed to, but it just drops the acid level for a period of time to let that inflammation resolve. And it was a beautifully, elegantly designed medication. As was the medication that preceded it, cimetidine, ranitidine, or famotidine, which pretty much stopped all production of
H2
all production of the stomach fluid, and allowed it to go downstream. And so I think when you're trying to get somebody off of a PPI, you educate them on what the PPI was for, try to get them onto a taper, and then explain to them that these other medications that initially came about can be used to supplement them and are actually much better for symptoms. If you have heartburn, you ate your chili dog, and you're like, oh, you should take a couple of Tums and a Zantac, and it will actually be a little bit more, maybe I shouldn't be using the brand names.
No, you can use it. So that's my take. I tell people that as you're tapering off for the proton pump inhibitor, the Prilosec type of thing, over the 2 or 3 month period of time, you have an acute episode of heartburn, Zantac, which is,
yes.
It's much faster. And so I would say the H2 blockers, fast, temporary, you don't be on them regularly.
Right.
The Prilosec, if you're on them regularly, you want to taper them if your doctor agrees with that. Now there's some people, like people who've had a Whipple, have been told they're stuck on a proton pump inhibitor all the rest of their lives. And so I'm on one, I have to be honest with you.
Yeah.
And I'm not happy about it, but my doctor said, and so I'm following what my doctor told me.
The connection that your operation created is at a much higher risk of developing an ulceration. So your acid level must be low.
Yeah. Now we have questions, which I so dearly appreciate. This program is your show. Your questions are key to the direction of our discussion. Call in your questions to 1-888-376-6225 or send us an email to ask@prairiedoc.org. A woman from Garrettson wonders, what advice would you give to someone who has a tortuous colon after having a perforated colon from colonoscopy? So she's got a tortuous, which means twisted and so on. So would you have any recommendation?
If she needs a colonoscopy, another colonoscopy, I'd recommend getting the report from the first one, trying to understand what happened to lead to that perforation. Is there anything we can do to not recreate that situation?
Right.
I think anesthesia helps out. The patient may be more relaxed asleep than maybe some of the medications we may administer ourselves. The prep will be helpful to be as clean as possible.
Really good.
Really good. And depending on how tortuous, maybe there's different colonoscopes. Some are thinner, some are more stiff, and that may affect your ability to get through some of those tortuous segments.
But no question about it, best colonoscopist there is, 1 in 1,000 is going to perforate. You're going to break through.
Yeah, statistic. 1 in 1,200.
It isn't going to be. It isn't going to be if. It's going to be when.
Anything we do has a complication.
And there is a risk, but it's well worth it because of the lives that are saved. I mean, it's clearly the risk. You have a perforation, they fix it, they go oftentimes home the next day, no big whoop.
I'm so sorry to hear about that lady's difficulty, or the patient's difficulty. Some men and women are different, as we know, and in my experience, women, especially as they get a little bit older and are more slender, can be some of the most challenging colonoscopies to do, and that's based on real anatomical differences between the way the colon is actually attached inside our abdomen. There are longer attachments and the colon is just more mobile. So as you're advancing the scope through these twists and turns, instead of the scope going through, you're just kind of pushing the colon around.
And stretching it.
Yes.
It's, you know, for a guy who's done a lot of colonoscopies, some of them are very challenging.
Mm-hmm. Some people will never, I mean, they just can't.
You can't get it done. There it is. We've got questions. Let's appreciate your questions. Keep them coming. One listener says, as 58-year-old man with scleroderma, I get severe abdominal pain about once a month, lasts 2 and 3 hours. Went to the ER, was given morphine, the pain didn't go away, they never found out the cause. How to manage the pain, any thoughts?
That would be a great patient to see in clinic and actually get some more details about their actual pain. The one thing from the history is that scleroderma. You know, that's something that kind of stands out in a history that can affect any segment of the GI tract, especially the motility of the GI tract.
Yeah.
So that would be a great clinic patient to sit down, sort out, make sure we have the right information, and sort through their pain, which it sounds like is the diagnosis is eluding so far. It sounds like a difficult diagnosis.
My guess would be it was a partial obstruction for a period of time. A twist, maybe it got scarred, you know, there's scar tissue, scleroderma, narrow area, got an obstruction. I think the major thing when I have a person who comes in with partial bowel obstruction, and you described it earlier, Jeff, I just tell them, stop drinking, stop eating, stop everything, lay low, wait for the pain to reside, bowel starts working again, and then you start with clear liquids and advance slowly. I mean, how many times have, and people who have this, they know exactly what to do. Oh gosh, here it comes again.
Right.
Hold off on any fluids or food or anything. Wait, right? And then you don't need the tube down your nose. Have you had a tube down your nose ever?
I have not, but I've ordered it a lot.
You've ordered a lot of that?
And it is not a fun thing to go through.
Have you had an NG tube down your nose?
No, I have not, Dr. Holm, but
You know I have.
I'm sure you have. Probably for a long
Oh my gosh. Caller from Trip asked the guest to discuss diverticulitis. Towner?
So diverticulitis is an inflammation of an outpouching in the colon, typically on the left side of the colon.
So it's left-sided more often.
Typically people come in maybe with a low-grade fever, their white blood cell count might be elevated, they have left-sided abdominal pain that may be progressive or slowly getting worse, and typically diagnosed with a CAT scan, make that diagnosis, and typically treated with antibiotics, and people do pretty darn well.
Yeah. When do they go to surgery?
Well, the colon is interesting structure, just like the rest of the bowel, but it's two tubes. It's a stretchy tube, very compliant, wrapped in this tube of muscle. And what happens is, as we get older, the tube of muscle starts to develop these little holes, and the inside starts to bubble out through those holes. And those inside, they just don't quite get enough blood flow, and that's what he's referring to, diverticulitis. And if the inflammation is repetitive, it keeps coming, round after round of antibiotics, in the hospital for IV antibiotics, partial, their colon's not even moving properly, then we'd have to consider going in and removing that segment of thickened colon. But that operation used to be done frequently. They're actually, if you got 2 episodes of diverticulitis, you come see the surgeon. But
it's not that.
It's not. No. We're giving people a little bit more latitude now because the risk of colon surgery is real, and some people do need it, but we aren't as aggressive on surgical therapy as we used to be.
And you're in agreement with that?
Yeah, I think the people who I've seen go to surgery, they've had a complication, an abscess, a fistula tract, or a connection between 2 different areas from that inflammation from the diverticulitis. A severe bout of diverticulitis is the main issue with that.
Yeah, they get into that abdomen with the surgery and it's a mess. It's infected.
Yep. And
then you end up drains and more adhesions, more partial bowel obstructions later. One listener stated, for the last 6 weeks, I've had mucus discharge from my rectum. It's gradually gotten worse. Any suggestions how to treat this condition? Mucus.
Mucus can be a common problem. Typically, not what we would call an alarm feature, may be associated with something as common as irritable bowel syndrome, which people hear as IBS. The question, other follow-up questions would be, is there blood associated with that? Do you have pain with that? Is there a change in your bowel habits? Are you losing weight? Some of these alarm symptoms, they would get us a little bit more concerned. Family history of colon cancer. Exactly.
And we do, that patient may require a colonoscopy. I mean, we do colonoscopies as often as an extension of the physical exam. That patient's having issues with something in their colon, we can't examine the colon unless we use a colonoscope.
I like the answer of a careful history and then an exam. I mean, you know, there's screening colonoscopies. You get one at 50, you get one at 60. Then there's a diagnostic colonoscopy. You got mucus coming from your bowel. Every once in a while there's blood. What's up in there? And you do the colonoscopy. All right. One listener stated, for the past 6 weeks I've had, I did that one. A man from Sioux Falls says, you talk about physical causes of stomach ache, but what about a nervous stomach? I get nervous sometimes and I can end up vomiting. That's in your territory.
So that could mean a whole heck of a lot of things. Anytime we hear vomiting, why are you vomiting? You want to rule out organic causes first. Is there
organic? I mean, real significant.
Is there an obstruction to the stomach? Is the stomach motility? Is the stomach actually moving the way it should? Is there inflammation of the stomach and with an infection like H. pylori?
And we can talk about H. pylori too, can't we?
Is it a medication side effect? Is there something outside the stomach that's causing the vomiting? Nervous stomach and functional or irritable bowel, I keep saying those words because they're very common, may cause vomiting in some people with some anxiety. That anxiety may change the nerve patterns and be associated with some of that vomiting, but that deserves further investigation to figure out what's really going on.
Yeah, we can presume it's no big deal, it's all in her head, she's nervous and it's a nervous stomach, but I'd like to make sure there isn't something else happening.
Exactly.
Yeah.
You could only tell her that it's just a nervous stomach after you've made sure, of course, that there isn't anything else. But it's worth noting that there are two big nerves coming right out of your brain, and they go right down your esophagus and just envelop the entire GI tract. And people that are nervous, as she stated, certainly that can have effects on how well the stomach is going to empty, how well her GI tract is going to move, and
our brain and our bodies are together.
Yes.
This is not two separate things.
That's right.
So those are real. My sense is that if we've done the workup and we know that it isn't something dangerous, for now, although we may do more workup later,
yeah,
let's try some things to help with stress. And my first recommendation is a regular exercise program. Now, would you have guessed I would have said that? So a walking program at least once a day for 15 to 30 minutes. Well, it's important to watch for gastrointestinal symptoms that seem to rise without warning.
When this first started, we was at a basketball game, and I just had a piece of pizza from there. By the time we got home, my lower area was like burning and very painful. That night, I called Dr. Holmes, and he was at a Christmas party, and kind of explained what was going on, and he arranged for a painkiller for me to take, and that eased the pain that night. And then it might have been a few days or so later, I was eating some French fries, and the French fries were a little on the greasier side, and it hit again with a vengeance. So from that, I kind of determined that maybe grease was causing my problem. When the pain was there, nothing would ease it other than a painkiller of some kind. And it would come and go. So we didn't know when it was going to happen. What I ate didn't seem to make a difference. When it attacked, it came on. And it was right up there with one of the worst pains I've ever had, and I've had a couple different. To find out what was causing the pain, Dr. Holmes was working with Dr. Wee, and she was the surgeon, and they kind of narrowed it down to the gallbladder. And they took some x-rays and some ultrasounds, and that's what they narrowed it down to. Well, the surgery with Dr. Wee was what I would say awesome. It's the first time I had ever been operated on by a robot, but the 3 little incisions, it was painless. After the surgery, it was no pain. I mean, it was just wonderful. But she found when she got it out that it was a stone that was lodged in the throat and had turned, I don't know what the word she used was, but it was like virus or something. It was infected. Since the surgery, I can do anything I want as far as that goes. And I've always been a French fry, greasy pizza eater. So no, there's been no after effects or problems at all. I would say from the first attack until it was removed, we probably weren't talking more than 4 to 6 weeks. Because when it came on, it was bad. And Dr. Holmes got me in with Dr. Wee, appointment with her, and she moved pretty fast on it.
Well, I thank my dear friend and patient for that story. I mean, the thing that really made a point to me was that we did all those workup things. The lab work, we did the ultrasound, we did everything negative. I said, well, it isn't gallbladder. I thought it was for sure gallbladder, not gallbladder. And then it came again. Well, we repeated it. We'll catch it. We didn't catch it. And finally, I said, Dr. Wee, I think this is gallbladder and all lab tests are normal. And she said, we'll solve the problem. And she did. So that was good. The reality is that no matter how good we think our tools are and all of the things that we have, sometimes they're wrong, and the truth is we just need to keep exploring.
there's an old general surgery saying that when in doubt, just take the gallbladder out.
and that's what we did,
Yep.
and it worked. We have a question. Our daughter is special needs, 37, and 3 years ago, she's 37, and 3 years ago had blood in her stools, and endoscopy was performed along with upper GI, and she had 3 precancerous polyps in her colon and an ulcer in her stoma, or stomach. He, along with her whole stomach, is covered in polyps. It's hard for us to judge if she had much pain, as she seems to have a high tolerance to pain. What causes this type of polyps in the stomach? We live in the beautiful Black Hills. Thank you so much for your call. So this person has polyps everywhere, stomach, colon. What does it mean?
So there's lots of different polyps that you can get in your stomach. Some are completely benign, some are due to inflammation in the stomach, some are due to medications that we talked about earlier, like PPIs. Some can lead to cancer if left in place. That is rare in the United States. However, if we have polyps in our stomach, polyps in our colon, is there a genetic syndrome that needs further evaluation to make sure there's nothing else going on that's causing those polyps to be there?
There are these genetic syndromes, are there not? What? Tell me about them.
There's lots of genetic syndromes. One of the ones we hear polyp and genetic syndrome is FAP, or familial adenomatous polyposis. Puts thousands of polyps in your colon. When we diagnose it, that needs to come out. Can put you at risk for other cancers.
I mean, you remove the colon.
The colon comes out.
Because each one of those 1,000 polyps has a chance of becoming a cancer. And so how are you can't, if you remove one, you got
1,000 more.
Yeah, exactly.
Yeah. So.
So there's, and that can also put polyps in other places and put you at risk for other cancers. So that definitely deserves more investigation.
Now we've got great questions, so I'm going to run through questions pretty fast now, okay? 50 years ago, I had a pyloroplasty and vagotomy. Because of these procedures, I'm less likely to have acid reflux symptoms, question mark. So that we used to do this when people had ulcers of the stomach, before the PPI, before the Prilosec and the Tagametes and so on and so forth.
Yeah, so that actually is an operation that surgeons of my vintage, if you will, have not done. It's just an operation that was done in the past to decrease the amount of acid that the stomach is producing, and it was somewhat effective. But the medications we have available now have really just made that operation, I wouldn't say obsolete, but it certainly. Would you rather take a pill every day or have your stomach operated on and the nerve supply disrupted?
The pill.
Yes.
Take the pill.
Yeah.
But is he less likely to have acid reflux symptoms now? I don't know the answer.
Well, if the vagotomy, if the pyloroplasty, which just makes the lower valve of the stomach open all the time, and the vagotomy was actually done as well to help with the acid production in the stomach, things should move through faster. But nerves are funny things. They can regrow and
redevelop.
Yeah. Did they get the right nerve? Did it slow down the stomach? Right. And now food's sitting there and putting them at risk for more reflux. So,
good question. I think it just depends upon how well he does, and you have to follow them clinically. Most of the time, I thought those people did fairly well, though, after the pyloroplasty.
Yes.
And a Sioux Falls woman says, I know a female with a kidney pancreas transplant. Her labs were good, but recently went to her OBGYN, and she had a lot of abdominal bloating, leaking, and pelvic pain. Doctors discovered a cyst on her ovary. Since then, she's had a 7-pound weight gain and continued pain. What could it be? What are the next steps? Good question.
That's a very complex.
Kidney, pancreas transplant. So she is immunocompromised. So it could be infections.
Yes.
And she's got a cyst on her ovary. That's not unusual.
She's had previous surgery on her abdomen.
Yeah.
She's had, she could have adhesions and scar tissue like we talked before. And then pelvic pain is a challenge. Leaking is another story that's difficult. That's probably unrelated. And weight gain, not related.
Potentially, I mean, very, very complex case. So, continue with imaging. The patient needs to be followed very carefully.
Work on their weight, exercise regularly.
Right.
You know, that's a really difficult issue.
It is.
A Brookings man asked about gastroparesis. Now, you alluded to gastroparesis, and I'm going to ask you what it is. Is it possible? How long will it take for it to heal itself? So what is gastroparesis, and what do you do for it?
Gastroparesis is basically a slow stomach, or the stomach doesn't empty in the normal amount of time. That can be due to lots of different things. Medications, narcotics, the most common is we don't know, or idiopathic. Diabetes is another common cause, or some of these other rheumatological scleroderma can cause affected GI tract motility.
Or vasectomy after pyloroplasty, like we just talked about in the case earlier. And
so I think how long will it take to heal itself? I think it depends on the cause and what is actually causing it, and has it been diagnosed correctly, and that's exactly what's going on.
If the patient is diabetic, they need to get their A1C and chronic blood sugars under control, because that, as one of the most common causes of gastroparesis, that's one of the things that you can fix.
It's sort of like the numbness in the feet that goes with diabetes. It's a neuropathy. They lose the vagal stimulant to cause the peristalsis to empty the stomach. Tough deal. Some people have that and there's nothing. Nope. You have to feed, they end up with feeding tubes.
Rare. We have some medications, but they have side effects and they may not work.
Right. A listener states, I thought I had IBS but was diagnosed with exocrine pancreatic insufficiency. The doctors prescribed me with Creon, which is pancreatic enzymes. What does medicine like this do for my condition? So that's I'm taking Creon, which is pancreatic enzymes that help dissolve protein, carbohydrate, fat. And I just have to say that Creon costs in the realm of $850. Used to be $30, but they proved that it worked. So now it's $850. Insurance will pay for half of it. So it's a very expensive medication. But it does, without it, having had the Whipple procedure and the surgery that I have a very undigested GI tract if I don't take it. It helps me digest the food that I eat.
So certain people with certain conditions have pancreatic exocrine insufficiency, meaning the pancreas is not producing enough enzymes to digest the foods that you were describing, and require that medication to supplement what they have left to have digestion. If she's had IBS, if she has diarrhea, sometimes we test stool tests which are falsely positive, and maybe that's what's going on. What is a diagnosis of her pancreas that has led to that? Does she have chronic pancreatitis? Has she had a surgery on her pancreas that has put her at risk for that? But with that history of IBS, it would be interesting to know how that diagnosis was made to get more information.
And I wonder if the Creon really works or not. I mean, is it something that really makes a difference? It's expensive, so you have comments?
Just that the questions are about some of the most complex causes of abdominal pain.
Thank you, people. No, but I mean, there you have it. This is what it's all about.
And this is why general surgeons like me, who just are called in for the glory work, like our last case, the guy has gallbladder problems, gallstone, done. He's eating pizza and cheeseburgers again.
Pizza and French fries.
And then with gastroparesis and exocrine pancreatic dysfunction, I'm certainly glad that
you have an endocrinologist. By the way, you are on call, and I know that you have your phone here, and you could leave at any moment. And I appreciate the fact that you still.
Well, I wouldn't miss it, Rick. Yeah.
This has been great fun. A woman from Iowa says, my husband had severe ulcers. He went through a knee replacement, has given antibiotics. It seems to have made the ulcers go away. Is that normal? Oh, what's the diagnosis?
Yeah. Well, it depends on what antibiotics, what else he's on. Does he have an infection called H. pylori in his stomach, or did he have medications like ibuprofen, Motrin, Aleve that led to those ulcers?
Yes, there it is too. Well, and that whole story about H. pylori and the guy who made that diagnosis in Australia, and that whole story, we could go two hours on H. pylori, but we've got a minute left and several questions left. Let's go here. An Aberdeen man is talking about a patient with colitis and how every time he eats, he has to go to the bathroom. The patient is losing magnesium as well. Been to the doctors in Aberdeen, but haven't found a cause or a medication. Thoughts?
So again, getting back to the colitis, what is the colitis? That is just like abdominal pain, it's a very, very broad term, meaning inflammation of the colon. We see it on imaging a lot and say, well, you have a CAT scan, you have colitis. Well, do you really have inflammation of the colon or not is the question. And then what type of inflammation?
And don't give up with your Aberdeen doctors.
No.
This is a very complex disease. Maybe another consult, but the point about it is this is a challenge. Colitis is a very interesting, challenging issue. A woman from Rapid City asked, where does C. diff fall into this discussion? How often can it be treated with antibiotics? C. diff?
So Clostridium difficile, which is what C. diff, it's a bacteria that normally occurs in our colon, but in very small numbers. If a patient is given antibiotics that disrupt the normal bacteria that live in our colon, that C. difficile grows.
So you don't want to use antibiotics unless absolutely
Yes.
needed. The last question, vagotomy in the 60, we don't have time. And now for the winner of tonight's Prairie Doc quiz question. The most useful tool in the diagnostic abdominal pain is A, ultrasound, B, x-ray, or the patient's history? The history, of course.
History.
And it was Rosemary Armstrong, a critical care nurse from Sioux Falls, who answered the question correctly. Thank you, Rosemary Armstrong, for participating. And a book will be in the mail to you soon. We'll be right back after this.
Have you heard? The Prairie Doc has a radio show. Listen to your local South Dakota radio station for Prairie Doc Conversations. This program features physicians and other health professionals discussing various medical topics important to you and your family. Ask your local radio station if they broadcast Prairie Doc Conversations.
Thank you for listening. Until next time, stay healthy out there, people. Understanding the story of acute appendicitis brings us to understand other causes for a belly ache or abdominal pain. Like other causes, appendicitis begins when there is a blockage of a smooth muscle tube. We have a lot of those smooth muscle tube, hollow transport tubes in our bodies, to include esophagus, stomach, small and large intestine, kidneys, ureters, bladders, urethra, the bile ducts, the pancreatic ducts, the gallbladder, fallopian tubes, and the uterus, and even the aorta and blood vessels. When anything blocks the forward moving, squeezing of one of these smooth muscle tubes, people have cramping, spasm-like pain that lets up and then it comes again later, with nausea and vomiting adding to the misery of the situation. Patients usually can't find a comfortable position and are all over the bed, moving and anxious. When appendicitis is just beginning, the pain is around the belly button. Other examples of pain from a smooth muscle tube blockage include blocked colon with a cancer, blocked kidney or ureter with a stone, perforating aortic aneurysm with obstructed flow, infection of the gallbladder with gallstone obstruction, and blocked fallopian tube with an ectopic pregnancy. As appendicitis worsens, pain moves from the belly button to the lower right abdomen and intensifies until either the blockage is resolved, usually with surgery or antibiotics, or appendix ruptures, spilling fecal material and infection out into the abdominal cavity. This causes severe infection and inflammation, especially affecting the smooth lining that surrounds the abdominal cavity. The lining has plenty of nerves, and thus this causes a new and exquisite type of pain. Now we have peritonitis, inflamed peritoneum, which causes the patient to stop moving, to become perfectly still, almost frozen to the table or bed, not wanting anyone to touch him. This is a dangerous situation, requires emergency intervention. Other examples of pain from peritonitis include perforated stomach ulcer or ruptured diverticuli or ruptured gallbladder or ruptured ovarian cyst. Clues as to what is causing either blocked smooth muscle tube or peritonitis pain come with the location of the pain, the history of the progression of the illness, and the physical examination. Laboratory and X-ray may also help. People with non-dangerous belly pain often have recurrent constipation, menstrual symptoms, or bladder infections and should seek help at the outpatient clinic. In contrast, some clues to bringing one to the emergency room should include progressive, unexplained, severe abdominal pain, shaking, chills, blood in the urine or stool. Understanding how a blocked smooth muscle tube or peritonitis happens with appendicitis helps in turn to explain the many possible causes of a bellyache. A big thank you to our guests, Jeff and Towner, for volunteering. This is purely, you know, I'm paying you 3 times what I get, which is nothing, to come to our studio at Yeager Hall on the campus of South Dakota State University. The experience and insights that they brought has been wonderful. Thank you both.
Thank you. Yeah, thank you.
We're in the midst of National Influenza Week, which is December 2nd through the 8th. The flu season is just getting going, but there's already been 1 death in South Dakota. If you haven't done so, please get your flu shot. If you're over 65, ask your healthcare provider about the higher dose vaccine. I took the higher dose vaccine. It's important not just for you, but to help protect the people who are immunocompromised or the little kids around who can't have protection. So and then from the Shameless Commerce division of this, I will be on a holiday book signing tour Monday, December 10th at Zambro's Variety in Sioux Falls. This coming Monday at 7 p.m., a little talk. Wednesday, December 12th at Watertown Event Center from 5:30 to 8 p.m., a little talk about. And Saturday, December 15th at the Dakota Prairie Museum in Aberdeen from 10 a.m. to noon. And in my hometown of De Smet at Ward's V-Store and Bakery on Wednesday, the 19th from 5 to 7 p.m. That does it for tonight from all of us here at On Call with the Prairie Doc. Until next time, stay healthy out there, people.
It was Mark Twain who told us, the finest clothing made is a person's own skin. But of course, society demands something more than this. Dermatology, next time, On Call with the Prairie Doc.
Hello to all. I am Dr. Tom Luzier, a practicing allergist in Aberdeen, South Dakota. Born in Kansas, I embraced the diversity of South Dakota. This diversity comes with a price: limited healthcare resources and information. The Healing Words Foundation, through Prairie Doc, provides an open, online, interactive, public broadcasting format for reliable health information. As a member of the Healing Words Foundation Board, I am asking you please to join me in support of this work, which is funded entirely by donations from you. Please consider making a personal or corporate gift to Healing Words Foundation, a 501c3. Go to prairiedoc.org and click on the donate button and make a valuable contribution. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. And with the ongoing support of these individuals and institutions. Brookings Health System, Ophthalmology Limited, American Academy of Family Physicians Foundation, and South Dakota Academy of Family Physicians. Avera Heart Hospital, Dakota Allergy and Asthma, CoBank, Fishback Financial Corporation, Vance Thompson Vision, Brown Clinic, Aberdeen District Medical Society, 3rd District Medical Society, 7th District Medical Society, Dakota Bank, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, Aberdeen Asthma and Allergy, and Swiftel Communications.